Actually, my name's Rajeev Pandarinath. I'm an orthopedic surgeon here at Washington Sports Medicine Institute. And as part of our lecture series today, I wanted to talk. You guys hearing me now? Okay. I wanted to talk to you a little bit about ACL injury prevention. And although it wasn't on the flyer at last minute edition, we also have one of our uh, uh, physical therapists specializing in sports medicine that's going to talk to you also about some of the criteria we use for return to play after ACL reconstruction. So we'll kind of cover before and after this devastating injury. And I wanted to start off by having this slide up here, which is basically one of the most devastating moments in Washington sports history, which is RG3 re-tearing his ACL. So kind of the hope and dream for the then Redskins to come back big, but unfortunately we're still working on that. So a little bit about me. So I'm originally from North Carolina. I lived there all of my childhood, and then went to Duke University for undergrad, and then decided to travel about 10 miles down the street to UNC Chapel Hill, which is where I went to medical school, and then got the bug to travel. So I went all the way to UCLA for residency and was in sunny California for about 5 years, where I met my wife, and then dragged her back to the cold East Coast, where I did a fellowship in sports medicine at Thomas Jefferson University in Philadelphia. For a large part of my career, I've been working at GW. So I was the director of sports medicine at George Washington University, and was the head team physician for the GW Colonials and later the UDC Firebirds. And I was there for about 10 years. I just joined the Washington Sports Medicine Institute this January, so I've been with the group for almost a year now. And we have offices in Tyson's Corner and Bethesda, and do surgeries in Arlington, Bethesda, and Reston. So a little basics on the ACL, and depending on who you are, you may or may not know some of this stuff. If it's too easy for you, I'm sorry. If it's too hard for you, I'll work on that too. But the ACL is short for the anterior cruciate ligament. It's a ligament that goes from the anterior tibia to the posterior lateral femur. It's right in the center of the knee, so it's not something you can feel. But it really has two functions. One, it keeps the tibia from moving anteriorly relative to the femur, and it also prevents abnormal rotation of the knee joint. So it really restricts your knee range of motion in two different directions. And it's important, most important, not when you're walking straight or jogging or something like that, where you're moving in a straight line, but more when you're cutting, pivoting, changing directions. So a lot of our athletes that play sports, but even in daily life, sometimes we just need to change directions. You're crossing the street and someone's coming right at you, you need to swerve around them. I mean, so you're relying on stability of your knee, and that's your ACL. It is one of the most common injuries in sports and accounts for about estimated 250,000 tears per year just in the United States. And one consequence of this is that people who have had ACL tears have a much higher risk of developing osteoarthritis later on in life. And recurrent instability prevents otherwise healthy young people from participating in the activities that they like to participate in. And an old statistic back in 2000, so you can calculate your own inflation, but at that time, the estimated cost of ACL reconstruction in the US was about $1.5 billion. So whatever magnitude greater that is now. And it's a long time to return to sports. So typically the return to sports after ACL reconstruction can be somewhere between 6 to 12 months. So there's really two kinds of ACL tears. So there's contact injuries. So like this rugby injury, for example, I would argue that no matter how much you try to prevent an ACL tear, this would tear your ACL no matter how much training you've done, how well you jump and land, how well you move. There's just so much force on the knee that it would tear anyone's ACL. So these are probably not the ones that we can prevent. The ones that we're trying to prevent are actually a majority of ACL injuries, which are non-contact injuries. So this is when people don't even get hit, but they have an injury to their knee from jumping and landing. So let's see, how do I get it? Can you start that? This is just a video I wanted to better demonstrate an ACL injury. You switch it to the So while he's getting this working, I mean, basically, is the video on? Okay. So if you have your knee, you have your tibia and your femur, and the ACL is right in between it. Oftentimes there's a twisting injury where the femur rotates back on the tibia. So this would be my lower fist is the tibia, upper fist is the femur. It rotates back like this, and then this bone slides forward. So that combination of motion causes ACL injury. So a lot of times when we have an ACL injury, we also have this impact from the two bones hitting together. Does that work now? Oh, this is better than my fists. Okay. So this is just showing like a soccer player's knee when they're planning and kicking the ball. And just to recap from what I was saying earlier, so we've got our femur and our tibia and the ACL running in between it. It looks like it's still playing in the background. Yeah. Yep. And then, so let me just, can I go back now?
Yeah, I can go back for you.
Maybe not that far, maybe like anyway, so okay, well, I'll go back to the fist example. So when the bones rotate back on each other, the femur actually contacts the back of the lateral side of the tibia. So a lot of times when that happens, people get these bone bruises in their bones. So they get a bone bruise in their lateral femur and their lateral tibia, and what gets pinched in between is the lateral meniscus. So a lot of acute ACL tears also have a lateral meniscus tear at the same time. Then chronically over time, when the bones are doing this abnormal sliding, the secondary restraint to that is the medial meniscus. So a lot of times, once people have had an ACL tear, then this starts to slide more, and then the medial meniscus acts like a doorstop, and it keeps the bone from sliding even further. And so people get chronic meniscus tears that are on the medial side. I mean, I think that's, we can just go back. I think the next video will work fine. Yeah. Yep. Okay. All right. So, why do people get non-contact injuries? A lot of it comes with the position and the forces on the knee when they land. So if you land with your heel, or if you land on your heel or your foot, then with your foot being relatively flat, then you put a lot more contact forces on the ACL versus if you land on your toe. So if you land like toe to heel, and then you gradually absorb that force over time. If you land flat on your feet or on the back of your heel, there is a much higher stress on the ACL. The other thing is how your hip is um, when when you land, and landing on a flex tip can be more dangerous as well, and the position of the knee. So a valgus knee, which is where your knee is going in like towards your other knee, um, also increases your risk for ACL injuries. So I can show that better on the next slide. Oh, well, it'll come up. So when you land, if you land on your foot flat, um, if somebody weighs about 70 kilograms, which is probably about 160, 170 pound person, it causes about 3,400 newtons of force. And it only takes about 2,000 newtons to tear your ACL. So you might wonder why you don't tear your ACL every time you land flat-footed. Well, the reason for that is that the calf muscle actually absorbs the ground reaction forces when you land. And so that's why when you're landing with a planted foot, you have the ability of your calf to even absorb more force. But this is a good diagram of like a safe versus unsafe landing. So um, on the first picture, you have the safe landing. So this person's landing with their toe pointed down and their hip is relatively extended. So they're not, so the angle of their knee is pretty flat. So like the top of their tibial plateau is relatively flat. But on the second landing, they're landing on their heel and their hip is flexed. So it's like the tibia is almost like a runway for the femur. It can just slide right off the top of it with the force pushing up on the ACL. And that's how ACL tears occur in non-contact injuries. It also seems like there's a contribution of valgus to the injury. So when people have their knees pointed together, there's we think that there are more forces on the ACL at that time and a greater rotational force on the knee. And then if you have both knees pointing towards each other in valgus and you're leaning over on that side of your knee, then that's even more forces on the same knee. So the tibial slope is something that you can actually measure even on an X-ray, but for and this is just kind of the way that you're built. This is nothing that we can change, but the slope of the tibia can affect the risk of an ACL tear. So in patients who have a high slope, so that would be like where, oh, this is not, let me get the laser pointer. So the tibial slope is this line from here to here. And in somebody with a high slope, so to exaggerate, that would be like if their slope goes from like here to up there, that would be a higher increase. That would be a higher risk of injury. And if it's a relatively flat slope, so like this line across, then there would be less stress on the ACL when they're landing. So for example, in dogs tear their ACL as they get older. And what the veterinarian often does is an osteotomy. So they actually change the slope of the tibia to make the knee more stable. They don't actually reconstruct ACLs in dogs. They just do an osteotomy and cut the bone, and that helps make the knee more stable. Also, it definitely seems like there's a higher propensity to tear the ACL in females over males, and we're not exactly sure why. there's some differences in gender that we notice in studies that compare joints of men and women. So females have a higher laxity to their joint. That just means that if you push their knee in different directions, there's more excursion. They tend to hyperextend their knees more often, and they have a higher posterior tibial sub, which we just talked about. It's unclear whether estrogen levels affect the rate of ACL tears as well. So what can we do to prevent ACL tears? This is why we're all here. So does bracing help? Should we do ACL injury prevention programs, or should we just stop playing sports at all? So bracing. So I want to go back to the picture that we had at the very beginning of the talk, and that's RG3 tearing his ACL. If we zoom in here, he is wearing a brace, a very common brace that we use to help protect people's knees when they have ACL tears. So obviously bracing does not always work. What does bracing do? Well, we know it's expensive, and it can slightly limit your range of motion. So even though these braces are actually very form-fitting and designed to play for sports, you know, they're still an extension that's not part of your body. So they can limit your flexion a little bit. They limit the rotation of the knee a little bit. And they did a study on Army cadets. So these are people that came, joined the Army, and they had already had ACL surgery, not in the Army, but they just had an ACL tear like in high school or something. And then they came and joined the Army. And they looked at people that, so the Army did not tell them whether to wear a brace or not. Some people were told by their surgeon to wear a brace, and other people they just said, go for it. I didn't find a significant difference. It wasn't a huge study, so there's about 50 people in each group. But at 2 years out, both groups had a small number of re-tears of the ACL. One thing that I do find that braces are really useful for is that the ACL injury tends to be very devastating. And so when people tear their ACLs, it's a big deal. They can't walk for a few days. They have surgery. They do a ton of physical therapy. And the last thing that they want to do is tear their ACL again. And so when they go back to play, they're very nervous to play. Like the mental part of returning to play is actually difficult because you just went through this whole 6-month process of recovering from your injury, and you're like, well, I never want to have that happen to me again. What, so they're terrified they're terrified to take aggressive moves in their sport. And so I think that the brace does give you some mental feedback on where your knee is in space. Just having the straps around your leg gives you some actual mental, like psychological support. But the other thing is that when you tear your ACL, besides just being a ligament, which would be like a piece of rope holding your bones together, the ACL is actually like a living thing, and it has nerves in it, and it sends feedback back to your brain about where your knee is in space. And so we know that the ACL graft may heal around by 6 months after surgery, and that's why we think you're ready to go back to play. But your nerves take longer to grow than almost any other type of tissue in your body. So the actual proprioception, which is knowing where your knee is in space, is not completely there when you first go back to play. So I think that the brace, just having that feedback of having the straps on your skin, can help your mind kind of know where your knee is and how your knee is moving, and give you some feedback to your brain. So typically for patients that really want to get back to sports as early as possible, once they're cleared by their physical therapist, I'll have them wear a brace for their first season back, just to help them with that mental assurance and possibly with the proprioceptive help. But if you look at the studies, it's hard to know if that is a definite help or not. And so I think the jury is still out for bracing. So then there's ACL injury prevention programs. So these are different programs that have been designed by physical therapists, surgeons, athletic trainers to help reduce the incidence of ACL injury in a given population. And there's different versions. Typically, they're supervised exercises with different frequencies and different periods of time. These are some programs that exist. I'm sure there's more than what I'm covering, but these are some of the injury prevention programs that have research studies behind them that have come out over the years. And they all have, different techniques. This is kind of a comparison of the program. So some of them involve strength training, some involve flexibility, balance mats. Some of them are things that you would do outside of the season. So like in the off season, you could do the program. And some of them are like during practice, and some are a combination of both. And you can see there's a big difference in how much time you have to devote to this too. But all of them require kind of a significant amount of time. Sometimes you would do it like the PEP program would be in the warm up for practice, whereas the sports metrics program it's 3 days a week for 6 weeks outside of the season. So there's different time commitments to any of these programs. The data does show that many of these programs can decrease ACL injuries. Now you have to take that with a grain of salt. So if we're going to try to find a difference, whether a program can prevent ACL tears, we need a large group of people, because if you have a whole soccer team, chances are that at the most maybe one person tears the ACL or no one. So you have to have tons of teams. You have to have all these people doing the same ACL prevention program. So it's a little difficult to show a difference. So most studies that look at ACL injury prevention would look at like female soccer players, because that's if you take all sports, that's one of the higher ACL tearing sports, and it's females and not males. So a lot of the studies will look at female soccer players and then kind of extrapolate that to everybody else. So every other sport and males as well. But generally, those risks would be lower. But in the sports metrics program, they had, for example, 366 trained females who did not tear their ACL during the study period, and about 463 controlled females that had 5 tears, and as I said, 434 controlled males that had 1 tear. So on one hand, it looks like, well, if you're a female soccer player, it really reduces your risk for having an ACL tear. If you're a male soccer player, it's not as high of a risk. I mean, it's almost 1/5 of the number of tears. So, and then the PEP program looked also at high school soccer females, had a bigger number, so in the thousands, and definitely showed a decrease in the number of tears in 2 different studies. One was in high school and one was in college. And cost is a real factor. So not everyone can afford to do the injury prevention programs. If a sport is provided by your school, but that can be free for the athlete, but then the actual prevention program costs money. It's typically not covered by insurance. And so this is something you would pay. For example, if you had an ACL tear, this is something you would pay after you had paid for your ACL surgery, all of your physical therapy afterwards, all the bracing you did, your time off of work or school. It's just another cost. So sometimes when people are done with the healing process from ACL surgery, the last thing they want to do is something else that costs money. But these things all cost money, and sometimes it can be paid for by the team, and sometimes it is not. The sports metric program does involve, as I said, sessions typically with supervised instruction and outside of the sport. And the PEP program is something that you could do at practice, but it takes 15 to 20 minutes additional to your practice and requires the coach's participation. There's a number of centers. This is just kind of a Google search on the sports metrics webpage. Don't want to really advertise for anybody, but there's plenty of places if you're interested that you could be involved in the sports metric program. And then this is kind of like the chart of information about the PEP program. And so like it's a warm up to practice done 3 times a week, and 15 or 20 minutes. And then they have just different sections of training. This was developed at the Santa Monica Sports Medicine Foundation, which does work with all kinds of athletes, but for the most part, they do a ton of soccer players. So the take-home points that I wanted to get across is that ACL prevention programs really do reduce the risk of ACL injuries. And in the most recent meta-analysis, where they tried to look at all the studies that had been done in the past on ACL prevention programs and then they excluded the ones that they felt weren't good studies. So they actually weeded out the ones that they didn't think had enough people or had the right kind of data measurements. They still found a reduction of 53% in ACL injury. And it's a sad fact that ACL injuries it's not just an injury to the ligament, but it causes a greater risk of obesity and greater risk of osteoarthritis later in life. So it has repercussions, and it's definitely something we want to avoid. And the National Association of Athletic Trainers recommends that any ACL injury prevention program you participate in should include at least three of these aspects: strength, plyometrics, agility, balance, and flexibility, and feedback on exercise technique. So it's not just doing the exercise, but someone's telling you that, hey, you're doing this right or wrong. But there have not been any head-to-head comparison of injury prevention programs, so it's hard to know what's superior. But I think it's definitely clear that doing an injury prevention program versus not doing one does make a difference. So we don't have all the answers yet, and there's a complex mechanism of injuries that involve tearing your ACL, and like I showed in that one picture of the rugby athlete, no matter what you do with your warm-ups and your off-season drills, unfortunately, some ACL injuries are totally unpreventable. But prevention programs can certainly decrease the occurrence of injury, but can be costly or time-consuming. And with that, I think we'll move on to John's presentation about returning to play after ACL injuries, and then we can take some questions if there's any questions at the end.
Okay, can everyone hear me? All right.
Oh,
Okay.
you make it so we can move?
All right. Thank you for having me join you in this lecture, Dr. Pandarinath. For everyone on the call, my name is John Dale, and I'm a sports physical therapist and the director of our sports physical therapy at Aligned Orthopedics and Sports Therapy in Bethesda. And, although challenging, returning an athlete to performance and preventing ACL injuries is possible. And, I like to think kind of returning someone to peak performance after this surgery. My mind goes right to Adrian Peterson, pictured here, who I think notoriously has made our job difficult because everyone says, well, he made it back to playing football in 4 months and was the NFL MVP in his first season back. I think it just kind of hits home that, although this isn't the norm, it shows us it can happen. People can go back, not get re-injured, and shed some light to how our sports medicine team does prevent and returns athletes to sport after this injury. So if Adrian Peterson can do it, everyone else can. Go to the next slide. So our goal here after this surgery is returning an athlete to unrestricted training or competition, but it needs to be more than just time out from that injury and surgery. It does need to be a gradual process because returning to a game requires unplanned movements, high speeds, quick reactions, and the confidence to do so, where many times that athlete is returning to the same sport that got them injured in the first place. We need to make sure that our returning to play is based off both objective and subjective findings. Which tests are the best? We're going to touch on that briefly towards the end of this. Although it does make it difficult because there are unclear definitions demonstrated throughout the literature, and those studies that do have data do have poor sample sizes, and there's a lack of consensus between authors. So again, we need to determine too, that it's not just a numbers game. We need to take a look at what our athletes look like and how do they feel performing. And as was mentioned before, there is a high risk for re-injury with a high prevalence of chronic knee pain and functional limitations after the surgery. And so, to really optimize our rehab process, returning someone to sport, we have to really take a look at, re-injury after ACL and why this might happen. So surgical techniques have really greatly evolved over the years to restore mechanical stability better than they ever have. However, 1 in 4 to 1 in 5 athletes will have a second knee injury with the incidence of a second ACL injury, whether it being the graft rupturing or the other knee being involved, ranges from 6 to 32%, depending on the study you look at, with one study showing as high as 44% in high-risk populations. And again, this number doesn't just happen immediately. We do see this risk lasting up to 2 years or 1 to 2 years after surgery. Next slide, please. Younger athletes are most at risk for a second injury, mostly due to increased exposures, increased times playing after the length of their careers is much longer than older athletes. Females are 16 times more likely to re-tear within 1 year when compared to healthy females of the same age. And also females are 4 times more likely to re-tear and 6 times more likely to have opposite leg tear compared to males within 1 year. And again, this number is still staggering at 24 months, where athletes are 6 times more likely, again, with females showing that higher re-tear rate up to 2 years after surgery. And so we can skip this slide. We'll go to the next one. Looking at this, why is this happening? This only helps to feed and improve our rehab and return to sport process. We see that in studies and with patients that biomechanical and neuromuscular faults are found in athletes even after they've been medically cleared to return to sport. And this can last for even many years following. We see abnormal movement patterns and weakness of the uninvolved limb that lasts up to 6 weeks after 6 months after surgery. We continue to see compensatory strategies on the uninvolved side, and they are risk factors for secondary injury. And so we see muscle weakness, pain, impaired movement patterns, poor neuromuscular control, difficulty returning to sport, and high risk for re-injury. And to me, it really speaks to something missing from our process. Are we really just not testing and looking at the right things? And so our sports therapists at Align, we really look to, in returning to sport, that it should be a continuum rather than a fixed place and time, right? That returning to a sport should be a gradual process where we're returning someone gradually and exposing them to these forces and over time. And this generally starts with a return to participation in the sport, and then gradually returning to practices and games. And then optimally, we want them to get to that third stage where they are returning to peak performance, where we see them performing better than they did before they were injured. Now, there are a lot of different tests. You can see there's a lot of factors, and I'm missing so many from this slide, but there's a lot of things that go into the decision that needs to be made. And you can just see a few of them here. And it's really multifactorial when trying to decide. So, it then goes to, speaking to why is our rehab process so important, and why is that rehab process so long? It's because all of these test results are the outcomes of our rehab process. Through the months and months that a patient spends in therapy, increased quality of the rehab provides improved results on these returning to test metrics. And again, using the continuum, returning to sport is not just a static moment in time, but really a dynamic and individual process for each athlete. So our approach at Aligned is moving through a performance-based rehab program where we're moving from more simple, initial recovery from the surgery, moving to complex, returning to ultimately unrestricted participation in someone's sport. And there's a lot of things that go into this. As we return to performance, we're taking in many factors at one time. We want to restore psychological confidence in someone's limb. We want to restore stability and symmetry from limb to limb. And we want to decrease the irritability of that joint to allow someone to load, strengthen, and perceive their limb as highly functional as soon as possible. From there, we work on restoring general mobility, increasing someone's tolerance to loading, and building up strength, power, and then getting to speed. And then as we improve these athletic qualities, we move into kind of the area of where we start to assess these and assess someone's readiness. Can go one more. And so although, we think of distinct phases for rehab, they really do overlap. And there is a lot of integration from phase to phase, just kind of speaking again to that continuum of care, continuum of returning to a sport. And so as we move from, post-op or recovery from our surgery, we really want to work on normalization of strength, power, and speed. Those are our big things, right? Athletes want to be the strongest, most powerful, and fastest. That's what kind of gives us our edge on the field. And so as we move into that, as we move into our movement assessments and injury prevention phase of our rehab, we look at our ACL specific testing and returning to sport and performance. One more. Well, two more. So, we've developed kind of this checklist, this initial battery of metrics to really look at, is someone ready to be tested in thinking of returning them back to some level of participation in sport. And again, when we're talking about returning to sport, we're not talking about, okay, you're done with rehab and you're just going back to play at 100%. It's beginning maybe if they're a soccer player, maybe starting some drills and some dribbling in place, or basketball player, allowing them to dribble the ball or attend practices and do some non-contact drills. So our checklist to initiate testing, followed by things that I consider non-negotiable that all athletes with an ACL injury need to perform well and pass with in order to move to the next stage. And then from there, not every athlete, in my opinion, has to complete the same battery of tests. It needs to be individualized, one, to someone's participation and athletic level, but also be specific to their sport. So you can see here a very, very, very busy slide looking at all the things that we factor into our decision in returning to sport, right? We go with that first phase, that checklist to initiate testing. Typically, patients start to achieve this around the 6-month mark when they start to feel somewhat normal and ready to do some more athletic and dynamic type movements. Our non-negotiable testing metrics assess qualities of strength, ability to perform single leg hop testing maneuvers. We get them on our force plates and look for symmetry and jump landing from a force output standpoint. And then we take a look at biomechanical screening, looking at the quality, stability, and strategy of trunk, hip, and knee movements during sport-specific and dynamic testing. From there, we move into more of our sport, position, and injury-specific testing, where we look at, if we look all the way on the left, it's much more busy looking at those athletes who are looking to return to high risk and contact sports, high risk being sports that require jumping, landing, cutting and pivoting, moderate risk sports, a little less contact, depending on the position and competition level, followed by low risk non-contact sports, each of them having different metrics and qualities that they need to return and pass testing with. From there, we move to a graded exposure program where we move from a level of high control, meaning the therapist and athlete move through simple movements that are more dynamic and sport specific, to a level of high chaos, unpredicted, unanticipated movements. From there, we move to non-contact, contact, and full integration in sport in practices, and then again full integration in team training, partial competitions, and then finally full competitions. And so we've developed and aligned this is a lot of stuff here on this slide. So on the next slide, each athlete that we start to take through this process, we filled a report card just to make it easy for everyone and could be consistent. I fill these out. I've sent them to our doctors. We'd go through these tests with our athletes and send them to the doctor, send the athlete home with one, can send it to coaches, athletic trainers, performance coaches, so that everyone is on the same board, on the same boat, and aligned with the decision and the part of the process where the athlete is. And so if we go to the next slide, just a sample of a patient of Dr. Pandarinath and I's that I did a couple months back, just kind of a sample of the metrics and the detail in which we send our athletes through. As you can see on the next slide, we have force plate metrics, going through the overall impression and risk level, giving activity recommendations and continued physical therapy recommendations that we give to our athletes, physicians, and really the whole decision-making team for that athlete. So kind of summarizing everything up, how do we know someone's ready? Obviously, tissue healing is key. The graft has to have some level of healing, and the joint cannot be irritable. We want to restore regular, normal, pain-free symmetrical movement, range of motion, and loading patterns to the lower extremities. Normalize entire lower limb and trunk strength, power, and speed. Identify, and not only identify, but address risk factors that can be addressed in rehab. We take a look at psychological readiness and confidence, as this is a huge factor in returning to sport. And that by itself can actually be an indicator. A low score of psychological readiness can actually indicate if someone is even ready to be tested for returning to sport. And low scores can also increase someone's risk of future injury. Again, we go through a variety of functional performance testing, a variety of dynamic movements in different planes and testing conditions that are individualized to that patient's sport and participation level, looking at quality, quantity, and symmetry, and then completion of this sport and specific greater exposure program and progression to return to sport and performance. So lastly, just kind of what have I learned doing this over the years? Return to a sport is just more than assessing strength in single leg hop tests. Our criteria is a minimal requirement to start on-field rehab rather than strict criteria for returning to sport. You could say is on-field rehab the bridge and missing link between our rehab in the clinic and returning to peak performance. The process needs to be individualized. We want to make the rehab process fun. Initialize long-term motor learning, involve the patients, and set realistic expectations.
Can they hear me? Oh, John, that was a great talk. I think just as much as John mentioned in his talk that the reconstruction options and technology has improved a lot over time, I would say the physical therapy has improved just as much or even more. My career is just short of 15 years so far, but I can tell you when we were in fellowship, a lot of times I'm watching my attendings that I was learning from, we would just see somebody 6 months after an ACL surgery, kind of look at their knee, look at their quads a little bit, they're about the same size, their knee's not swollen, tell them to go back and play. And to be able to have this system with like a report card, and it really holds us accountable to a lot more factors that we cannot measure in the clinic, that we need, equipment and trained eyes to look at, to see. And I think it hopefully will reduce the number of people that get re-injured right when they get back to sports. Because as he also mentioned, when you go back after an ACL injury, we worry about you re-tearing the ACL that you just had surgery on, but also if you are weak or not ready for a sporting event, you can just as likely compensate and injure the contralateral knee as well. So do we have any questions from you guys that are here? No. We have a question from our virtual audience. So a gentleman asked if you have an injury to your cruciate ligaments that is not treated surgically for a long time, what kinds of complications can occur? And I think the biggest thing is probably developing meniscal tears over time, developing injury to your cartilage, which would manifest itself at a later age as osteoarthritis. Fortunately, if you do develop arthritis over time and your knees lasted you to an older age, and the gentleman's asking about age 82, at that point in time, I think that doing a knee replacement would actually help, and it substitutes for your cruciate ligaments, so you would not have instability anymore after a knee replacement. The people with arthritis that we really worry the most about are the ones that a 30-year-old, a 40-year-old, a 50-year-old with arthritis. The options are much more limited because knee replacements don't work as well in that population. Anything else? Okay, well, I just wanted to thank everyone for coming, joining in person and virtually. It's a collaboration of an effort that we have between surgeons and physical therapists at Aligned Orthopedics, and I think we're both integral to each other being good at what they do. So thanks for being here.
Thank you.
Thanks, everyone.
Thanks, John.